Hello, welcome everyone. We will get started in a minute. It's about 1 minute to 7 and we're going to try to be timely. So thank you all for those of you who have joined us already, and we'll be with you shortly. Oh. Okay, we'd like to get started. Welcome to our Urogynecology webinar hosted by Inspira Health Spirit of Women program. My name is Laurie Trongone and I'm the Assistant Vice President for Women's and Children here at Inspira Health. I'd like to thank you for joining us tonight. To our returning guests, welcome back. To our first-time guests, welcome, and we hope you have a great experience tonight. And to all of you, we hope you learn a lot. So before we get started, I'd like to touch on some reminders regarding our Zoom format. Get comfortable. That's the luxury of a virtual event, so that's a good thing. I hope you took care of any potty issues before we started, or you'll be the first in line to discuss with Dr. Chong any leaking that you might experience. And please note, we cannot hear or see you. The only audio and video that is turned on right now is by our panelists. As we begin, you'll see some slides appear on the screen as well as a section for questions. On your screen, you'll see a box labeled Q&A. Feel free to submit your questions throughout the presentation, and we'll address as many as possible at the end. Your questions will only be visible to us, the panelists, and those of us who are working behind the scenes to bring you this webinar tonight. So if you'd like to keep your identity anonymous, you can check a box that says anonymous before submitting your questions, but we do hope you'll feel comfortable enough to ask whatever questions are on your mind. Throughout the presentation, you'll see questions pop on your screen called poll questions. Most of those will either be true or false or multiple choice, and we encourage you to participate. It's what makes this session fun. So once again, tonight we have a relevant topic to discuss with you: leaky pipes. Incontinence and all that entails will be discussed with you tonight by Dr. Chong. And so with that, I'd like to introduce Dr. Chong, who's with you there on your screen. Hello, Dr. Chong.
Hello.
She is a urogynecology physician who's board certified in obstetrics and gynecology, as well as fellowship trained and board eligible in female pelvic medicine and reconstructive surgery. She completed her medical school at Morsani College of Medicine at the University of South Florida. Then she completed her residency in obstetrics and gynecology from the Albert Einstein College of Medicine at Montefiore Medical Center. And then she did her fellowship in female pelvic medicine and reconstructive surgery at Mount Sinai School of Medicine. She worked as the assistant professor and assistant female pelvic medicine and reconstructive surgery program director at Mount Sinai Medical Center before she joined us here at Inspira. We're very pleased to have Dr. Chong as a member of our Inspira Medical Group family of physicians. Thank you, Dr. Chong, for joining us tonight, and we look forward to your insight and how we can help ourselves deal with the various issues we face as women.
Thank you, Laurie.
Okay,
Thank you, Laurie.
Oh, you're welcome. So first, let me just say that the following is not intended to be a substitute for the professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions that you might have regarding any medical conditions that you might experience. So,
good evening.
What is urinary incontinence?
Laurie, I think we're moving a little fast. Good evening, this is Dr. Chong. Thank you for attending our first urogynecology webinar organized by Spirit of Women. Tonight, I would like to talk about urinary incontinence with you, as Laurie discussed about. Before I start, I do not have anything to disclose about this talk. Going back to Laurie's question, What is urinary incontinence? It describes any urinary leakage without your control. Many different things can cause urinary leakage. If anything goes wrong, such as when the bladder is getting full with the urine or when you are trying to empty the bladder, people do leak urine.
So let's do a poll question. True or false? Urinary incontinence is a normal part of aging. So let's see what our attendees think. We'll give you a second to do that. And then we'll have, we'll get the results and then we'll have Dr. Chong answer for us. So what did you all think? True or false? Is incontinence a normal part of aging? Okay. So most of you think false. That's great. Dr. Chong, can you tell us then?
Sure.
What is the prevalence?
Of course. So it's very common to have urinary leakage. In the United States, 17 million people leak urine. Although the rate of urinary leakage is associated with aging, it's not part of the natural aging process. Good job for everybody.
Very good. So let's ask you another question. Another true or false question. Do women have a greater prevalence of urinary incontinence than men? Once again, we'll give you a minute to answer that, and then we'll have Dr. Chong give us the answer. Okay, so most people think true, that women have a greater prevalence of urinary incontinence. Dr. Chong, you want to tell us what the true answer is?
You guys are so smart. Unfortunately, women leak more urine than men do. In addition, urinary leakage rate goes up with age too.
Very good. So what are the causes of urinary incontinence?
Many conditions can cause urinary leakage. Some are related to urinary system itself, others are not. Things like bladder storage problems, abnormal holes in the bladder, or abnormal anatomy can cause urinary leakage. In addition, if you have neurologic conditions like brain tumor, spinal cord injury, dementia, Parkinson's disease, you may not be able to control your urination. Certain medical problems or medications also can cause urinary leakage.
So are there different types of urinary incontinence?
Yes, there are mainly 3 types of urinary incontinence in neurologically intact people. First one is called stress incontinence. As it says, anytime there is stress on your bladder, like laughing, coughing, jumping, changing position, extra urinary leakage can occur. This is the most common type. Up to 50 to 70% of women can experience this type of leakage. The second one is called urgency incontinence. You may leak urine if you cannot get to the bathroom right away after feeling urgency. The bladder is contracting too quickly, even if the bladder is not full. The third type is called mixed incontinence. These women tend to have both urinary leakage from stress and urgency.
So let's ask our attendees, how much, this is a multiple choice question, how much liquid can your bladder hold? 1 cup, 2 cup, or 3 cups? Remember, a cup is about 8 ounces. So let's see what you all think. And then we'll have, once again, Dr. Chong explain to us how much it can hold. So we'll give you a moment. So most people think, 53% of you think 2 cups, 33% think 3 cups, and the rest of us think 1 cup. So Dr. Chong, tell us what our bladder can hold.
Sure. So I think all of you who answered this question may be all right, because the bladder is a hollow and muscular organ that collects, stores urine from the kidneys before disposal by urination, which means, like a balloon, bladder can expand as much as it can, as long as you can hold your urination. So if urine enters the bladder via the uterus, which are the small tubes connecting the kidneys to the bladder, and then urine goes out through the urethra at the time when you're urinating. The typical human bladder can hold between 10 to 16 ounces before the urge to empty occurs. But it can hold considerably more if you're a teacher or working in the OR setting as a nurse, because by training, bladder can hold up to 20 ounces as well. But normally about 10 ounces is around the average amount.
And I can attest to that, being a nurse, that my bladder holds way more than that. So tell us then, what could go wrong?
Sure. If you don't mind, okay. Each time we eat or drink, our body absorbs liquid. These liquids pass through the kidneys, which filter out waste and extra water to make urine. The bladder stores this urine. Once the bladder is full, it signals the brain, and then it makes us to think it's time to go. So our brain and nerves control the bladder. Anything that can impact any of these pathways can impact our bladder function.
So when things do go wrong, we'll have people come to the urogynecology office at Inspira. What can people expect, though, that when they do get to the office?
When you come to my office, these are the expectations. You may interfere. You will receive a package in advance from my office asking questions about your urinary symptoms. And please have the bladder diary done before you come to visit my office. It will help us out a lot. On the day of your visit, you will be greeted by my awesome staff, and then we'll talk about your symptoms and histories and perform exams.
So you mentioned a bladder diary. Let's ask our attendees if they know what a bladder diary is. So is it a fancy journal where you vent about your frustrations with your bladder, which we can all attest to? Is it a way to record your daily urinary habits? Or is it a strip of paper that you urinate on to test your urine? Let's see what people think. Fancy journal, a way to record your daily urinary habits, or a strip of paper to test your urine? All right, so, well, that was a good question. 100% of the people said it is a daily diary. So tell us about the daily diary.
Sure, great job. Yeah, so I ask my patients to do bladder diary, typically between 1 to 3 days for 24 hours consecutively. It helps me to determine your urinary frequency or types and severity of urinary leakage. It also helps you to recognize your urinary and incontinence patterns. So you will be also asked some detailed questions related to your urinary symptoms. This slide represents some of the example questions.
So are there any medications that might affect our bladder urination patterns, whether we have frequency or more of an urge to go?
Definitely. People shows some of the medications that can impact your bladder. For example, water pills we take a lot can make you urinate more often, more frequent, with more urgency. Any caffeinated drinks such as coffee and tea can make you urinate more often with urgency as well. Some bladder medications can make you not able to empty your bladder completely at times. Other medications like depression medications, bipolar medication can also impact our bladder.
Okay. So what kind of testing can we expect to determine whether or not we have urinary incontinence?
During exam in my office, so I start with basic physical exam and basic pelvic exam that you expect in regular gynecology exam. On top of that, there will be something called pelvic organ prolapse quantification, as well as urine test.
Okay. So can you explain what some of those tests mean?
Definitely. So further testing may be required for proper management, which include urodynamic testing, Cystourethroscopy, or imagings like ultrasound, CT scan, or MRI as needed.
Okay. So let's look at some of those.
Simple cystometry involves with filling your bladder with sterile water while you're sitting down comfortably. This gives information about your bladder capacity, how much your bladder can hold comfortably, and if you have any urinary leakage by urgency or stress. Another type of testing is called multi-channel urodynamic testing. Simply put, I just call it urodynamics or urodynamic testing. It's very similar to simple cystometry, but it's very much more complex and gives me more detailed information about how your bladder is doing, how your urethra and pelvic floor muscles are functioning. It takes about 30 to 45 minutes to complete the testing in my office. Another thing that I usually do in my office is also called Cystourethroscopy. Basically, I place a small scope inside the bladder to evaluate your bladder and urethra. While the test is carried out, you can also see all the live images with me through the screen right in front of you.
So then, can you tell us what happens after you get the information from some of these tests? Like what are the issues and what are maybe some of the options that we might have?
Of course, once all necessary evaluation is done, management options will be discussed with you at personal level, depending on what type of urinary incontinence you have. So generally, I start with conservative management. If you can advance to next slide, Lori.
Sure.
Conservative management includes like bladder training, fluid management, weight loss, pelvic floor muscle exercises. These are the main things that I recommend first.
Okay.
And the next slide, just like the way we got potty trained when we were young, patients with urinary leakage get benefits with retraining the bladder. By timed and frequent urination with good urination habits, we can reduce the urinary leakage episodes dramatically. You will be asked to increase time between urinations by 30 to 60 minutes if no leaking, with goal of urination every 3 hours. During the day while you're awake, you don't have to wake up at nighttime to keep it up.
Okay, okay. So I'll bet most people have heard of the Kegel exercises. So let's see if people know what that means. Let's ask. So Kegels, is it a type of bird related to a seagull? Is it a bagel shaped like a key? Or is it an exercise to strengthen your pelvic floor muscles? Let's see what people think.
Ooh. Ooh.
So 96% of you think it's an exercise, and I'm hoping that the person who thinks it's a bird related to a seagull is having fun, since we were.
Oh, wow, that was really fun question. So you all heard about Kegel exercises multiple times. Indeed, that was first popularized by Dr. Kegel in the 1940s. Just like other things, we tend to give some credits to person who developed something. So this is the same thing, it's somebody's last name. So pelvic floor muscle therapy can reduce incontinence to like 60 to 85% if you do it right persistently. I'll teach you what muscles to squeeze during the exam. And you should squeeze those muscles for 3 seconds, then completely relax for 3 seconds. Repeat this for up to 10 cycles back to back, more than 3 sets a day. You can slowly increase the duration of squeeze and relax the muscles up to 10 seconds, 1 second increment every week.
Okay, so at the bottom of your screen, there's a little hand to raise, and I'd like to know how many people are doing Kegels right now. If you can raise your hand. That's a lot of people.
Is it?
We figured that would be the case. Most of you are doing Kegels.
Oh, wow.
So then let's talk about some other options for you.
Sure. So for those who need help to identify correct pelvic floor muscles, biofeedback and electrostimulation can help you to get immediate feedback of how you're doing in terms of contracting your pelvic floor muscles. Electrical stimulation of pelvic floor has been used since 1952, and stimulation can be applied usually for 15 minutes at a time. It's very effective for all urinary incontinence types, stress, urgency, or mixed.
So let's talk about some management.
Of course. So for urgency incontinence, besides behavioral therapy we just discussed about, by mouth medications or Botox injection in the bladder, nerve stimulations work great for patients with urgency incontinence. In terms of nerve stimulations, there are 2 ways of helping current setting. One is called percutaneous tibial nerve stimulation. It's very mouthful, but it's basically placing a small acupuncture needle on the ankle to give some electronic stimulations for 30 minutes each time, weekly up to 12 weeks to complete the treatment. Another nerve stimulation involves with direct stimulation of sacral nerve in your pelvis. It can be tested in my office with a temporary stimulator and external battery to see if your bladder would respond well or not to this type of treatment. If your bladder symptoms get better, more than 50% from your baseline, you can get permanent stimulator with internal battery. Currently, the battery needs to be replaced every 5 to 7 years, but it's like a pacemaker for the bladder.
Wow. So what can you tell us about stress incontinence, like because I think a lot of us have stress incontinence, and can you explain to us what some of the management might be for that?
Definitely. To manage stress incontinence, besides behavioral modifications that we talked about previously, non-surgical management with diaphragm-like device, we call the pessary, or special tampons in the vagina can be tried. So there are special tampons, commercial name is listed on top of my slide up there. There are several surgical options to treat bothersome stress incontinence, including urethral bulking, slings, or suspension of the urethra from the belly. So for patients with continuous leakage of urine due to lead pipe urethra, these patients tend to leak urine almost persistently whenever they have little movement or have severe type of stress incontinence. I suggest bulking agents for this type of patient. It's basically injecting bulking beads or materials inside the urethra using the cystoscope. So it's an office procedure. You come in and get the procedure done while you're awake, and you go home right after the procedure.
Okay.
This slide shows a lot of little diagrams of common types of surgical management for stress urinary incontinence. I do not want to go into too much technical details, but I want to help you to understand that there are many ways of treating stress incontinence surgically. Most of these surgeries are day surgery, except one that I have to open your belly to place to suspend your urethra from above. All other surgeries, patients go home same day after the procedure. I can tell you more details when you come to see me in office if you do have this type of severe stress incontinence.
Okay. Oops. So tell us in conclusion, we'll wrap it up and then we'll do some questions.
Sounds good. So in conclusion, you're not alone if you have urinary leakage problems. Up to 50% of women have leakage issues, even higher when we're getting older after 70 or 80 years old. Thorough history from you describing your urinary leakage symptoms really helped me to figure out what the true problems are. Once we know the causes of your urinary leakage by thorough history, physical exam, and necessary testing, Urogynecology office at Inspira can definitely help you to have your urinary issues under control.
Great. So we do have a couple of questions. What is the difference between a prolapsed bladder and a prolapsed vagina?
That's a great question. I would put that in this way. They are basically the same thing. So in our pelvis, we have 3 holes, unlike men. I'm going to just put it in this way. When we're looking up from between the legs in women, there are 3 holes. One hole is urethra meatus, I call it. It's opening from the urethra, which is connected to the bladder and releasing urine. That is sitting on top of the vagina. The middle side hole, which is larger, that's called vagina, which is connected to our cervix and uterus. And right below there, we have another hole, which is anus, which is connected to our rectum and intestines for our bowel movement. So when we're looking at the vagina itself as a cylinder shape or some sort of box shape, think about the long rectangular shape box. I hope I have something. Okay, what about tissue box? Okay, this is the vagina here. Urethra is sitting on top. Bladder is sitting on top of our vagina. And there is a rectum, which is connected to the bowel, bottom side of the vagina. So prolapsed bladder means if bladder is pushing down the vaginal wall anteriorly, then what you see is indeed prolapsed vagina. However, the prolapsed vagina is caused by prolapsed bladder, which is sitting on top of the vaginal wall.
Okay.
Did I explain okay?
I think so. We have a couple more questions.
Sure.
One says, I'm a 69-year-old female, and with no notice, I all of a sudden have a decreased strength of my urinary flow. I really have to use my abdominal muscles to completely empty my bladder. Frequently, I have to double void also to feel that my bladder is empty. What's going on?
That's really good question. So I didn't get into too much physiology of our bladder and urethra. I briefly mentioned about our bladder is like a balloon. Balloon does have top portion and then narrow neck, right? So the top portion of the balloon part is actually bladder body, and lower part of the little neck is our urethra. In order for us to have urination, squeezing the urine right, we need to have enough force from the body of the bladder. At the same time, little tube has to be relaxed so that urine can flow out with this squeeze and open up the tube, right? But at times, as we're getting older, after we hit menopause, estrogen not around anymore, this is squeezing, I call it contractility, which means it's squeezing power of the muscle goes down. When this squeezing muscle goes down, then your urine flow tend to go slow. That's one reason. Another reason that can happen why we're having slow urine stream is even if you have force enough, if your urethra is surrounded by pelvic floor muscles. If your pelvic floor muscle is too tight, not relaxing when it's squeezing, then you're not going to have good flow. Thirdly, another common reason women come to see me is when bladder prolapsed. When you have vaginal prolapse, uterine prolapse, anything coming through your vaginal wall, then it kind of kinks the angle of the bladder to the urethra. So it's not actually coming out the way it's supposed to flow because it's obstructing your outflow tract. There are multiple reasons that can cause your urinary stream slow or not empty. Don't feel like you're emptying completely. That's why we need to have history, exam, and proper testing, making sure we are actually dealing with the correct diagnosis.
Okay.
But what in terms of double voiding, which is actually a good habit, but if you continue to have valsalva voiding, like giving your pressure from belly, that can indeed impact your upper urinary tract, such as kidneys. So you need to have some workup done, making sure we can protect your upper urinary tracts, such as kidneys.
Okay, thank you.
Okay.
Another question is, I find myself urinating at night about 5 to 10 times. Is there something that can be done for that, or is that an indicator of another possible issue?
That's also one of the very common conditions women come to see me. Professional name for the condition is nocturia. So, nocturnal urination, combined words, nocturia. So people who have to get up at nighttime from the sleep because of the urge to urinate more than one time per night, then you get the diagnosis of nocturia. The reason why women tend to get up or men tend to get up at nighttime are slightly different. Men's case, they have prostate glands. So when it gets inflamed, it keeps giving some contractions, so they have to go more often. But that kind of condition women don't have. Yet women can have something like if you're a snoring person at nighttime, and if you're snoring, if you're not using CPAP or BiPAP, whatever, for breathing helping machines, then at nighttime, you're gonna have lack of oxygen while you're in sleep because of snoring pattern. That will increase specific hormone in your heart. So that specific hormone will be released and causing your kidneys make more urine. So once your bladder is getting full and making more urine, you have to get up to empty, otherwise you're gonna leak while you're in sleep. That's one reason. Another more common reason is though, if you have high blood pressure, you're taking water pills and other beta blocker or some sort of like different medications, multiple of them. And if you're taking it in the evening time or afternoon time, type of medication also makes more urine because when you have a high blood pressure, body wants to get rid of sodium as well as water so that we can control your blood pressure low. In order to do that, we have to release more urine. So if that happens at nighttime, your bladder has limited capacity and your is making a lot of urine even if you're in sleep, then you have to get up. And another possibility is though, if you do have daily urinary leakage, daily urinary urgency and frequency, then it could be part of something called overactive bladder, meaning your bladder capacity is smaller than other people. You cannot hold the regular amount, so you need to get up to empty because the action from your brain to bladder is still intact. That is making you awake, be aware of your bladder is getting full. And there are a bunch of other reasons why you ended up getting a lot at nighttime. So that's why history is very important to figure out what other medical problems you have and what medication you're taking. And also another common thing is there's a special hormone called anti-diuretic hormones. Humans we sleep at nighttime. So in order to have good night's sleep, body is very smart. It makes some special hormone to reduce urine production while we are in sleep. But some people have some messed up hormonal system, so they do not make their hormone accordingly. So even if you are in sleep, your body still makes the same amount of urine when you're awake. Then you have to get up a lot to urinate. So there are ways of help, but initial approach will be very simple, starting something simple like behavioral modifications. As if you're taking water pill, if you're taking blood pressure medication, make sure you take it during the day while you're awake, at least 6 to 8 hours before your bedtime, so that it does not impact you. And after dinner time, make sure you don't drink fluid, no water, so that your body does not have a lot of water around right before your bedtime. And right before your bedtime, try to do double void, meaning go to bathroom even if you don't want to get out from the bed. Just make sure you go to bathroom, empty your bladder at least twice at the same time. So completely empty your bladder will help you not get up much. And sometimes women can leak urine if they just try to sleep through or sleep a little more hours, and in the morning when they get up, they cannot get to the bathroom because bladder is so full now and not enough time to get to the bathroom, and that's the time some people leak urine as well, especially people who have nocturia. Yeah, but something simple like this, food control, medication timing, and if you do have leg swelling, I forgot to also mention that one of the reasons women have frequent urination at nighttime is if they do have something called cardiac heart failure. They may not have full-blown heart failure yet, but these women tend to have both legs swollen. So at the end of the day, if you press your ankle area, your skin dimples and do not come back right away, then means your legs are swollen. If you are like this, I strongly suggest use compression stockings during the day. And nighttime, after dinner time, while you're watching TV and talking, make sure you elevate your legs so that whatever water retained in your legs during the day can go back to your kidneys before you go to sleep. Otherwise, once you lie down to go to sleep, all that retained fluid from your legs will go back to your kidneys and making more urine. So they are all connected issues. Not only one can cause condition, multiple things can cause one simple conditions, which can bother us a lot, because if you have to get up more than 2 times at nighttime, you're very tired next day.
Yeah, for sure. So another question is, we talked about Kegel exercise. Does stress incontinence respond to the Kegels?
Definitely. Kegel exercise works for everything. Sounds like it's for, if you do it right and long enough and your condition is not severe, just mild state, then Kegel exercise indeed take care of multiple things, including prolapse, which means like falling out through the vagina, having vaginal bulge stuff, including stress incontinence, urgency incontinence, which means mixed incontinence. People with mixed incontinence will be will get benefits from Kegel exercise too. Earlier, I didn't get into details, but this Kegel exercise, you need to be persistent, determined, more than 3 to 6 months. The result from having Kegel exercise, it's not gonna come back to you with good result within weeks. It takes months. So be patient and persistently doing it, along with bladder training, which means you need to make sure you gotta empty your bladder on clock, not with your brain saying, oh, I gotta go. Don't wait until then. Make sure you go to bathroom within, let's say, if your urinary frequency is, let's say, you go bathroom 30 minutes or 60 minutes every day during the day, then your goal to start is about 90 minutes. You need to try to distract yourself between 90 minutes and go to bathroom every 90 minutes so that you can train your bladder. But if you are patients who go to bathroom to urinate during the day, maybe once in a while, like in 6 hours, these people, you need to make sure you gotta go have bathroom breaks and needs every 2 to 3 hours while you're awake. So the pattern of urination really helps even before we get into medications and all other stuff, because changing your habits indeed help your bladder a lot. And if you indeed have a lot of urinary frequency and urgency, despite the fact that you don't have any infection from the bladder, then sometimes certain foods can impact your bladder a lot. We talked about caffeinated drink, coffee, tea. Some people asking me, what about I drink only decaffeinated coffee? Caffeinated coffee also has a little bit of caffeine too. So the study shows that do not drink more than 2 cups a day of coffee or tea. Then that will help your urinary frequency, urgency, all that bladder irritation. Alcohol, smoking. For some people, like certain food like citrus juice, orange juice, tomato juice, chocolate, everybody behaves differently, but basically things that I just listed, indeed, they have known effect in the bladder to irritate.
Another question, is a Cystourethroscopy painful?
I'm not gonna say you're not gonna feel anything. So it's basically when you come to see me, at times I need to see whether you are emptying your bladder completely or not. For that portion, I use about 10 francs, about like smaller than straw size, like smaller than this straw, clean, sterile one goes into your urethra. If you can tolerate this testing without problem, Cystourethroscopy is not painful. So it's the same idea. If urethra is here like this, then the scope is about this size or a little smaller, okay? And I also give you lidocaine jelly outside so that you don't feel, and making sure outside is a little numb. And once we, by the way, woman's urethra is only this much, about an inch length. It's not that long, unlike men. So once I pass this scope, we get into the bladder right away. So once we get into the bladder, we sit together and people don't know, don't feel much pain at all, because it's the tool itself is not that huge. And that's the reason that I do this without problem in office.
Okay, thank you. One of our participants said, my doctor has suggested a bladder sling. I'm 65 years old and have heart disease and sleep apnea. Is there anything else that is successful to do before I agree to surgery? And how good is the success rate for surgery? And it says, what doctor do you recommend? But obviously we would recommend you.
That's really pertinent question. And also it fits to our webinar presentation today. For stress urinary incontinence, any condition you have, it's really worthwhile to try something most conservative. For instance, stress incontinence, if you lose a couple of pounds, that reduce your leakage episode more than 50%. That's one. And secondly, if you have lung problem and have chronic cough and chronic lung problem, then controlling your medical issues, which means cut down the number of coughs or bearing down episodes, then your stress urinary leakage improves dramatically. And again, Kegel exercise we talked about, that's also helping for stress urinary incontinence. But even if you tried all of this behavioral modification and whatever, if you still leak, it's also worthwhile to think about incontinence pessary. Earlier I briefly said it's kind of diaphragm-like, made of silicone, small flexible device going inside the vagina and lift the bladder and urethra neck up so that it does not leak as much. However, if you try these conservative measures and if you're still not happy with final outcomes, indeed, for stress incontinence, surgical management are really great option, because especially something called mid-urethral slings, which became gold standard for stress incontinence women. It's made of synthetic polypropylene mesh. It's the mesh material, but it is heavily studied and FDA approved, and it's the success rate goes up to 95%. So that's one type. I didn't get into surgical options earlier, but that's the most popular and most proven and most effective therapy for stress incontinence. However, you need to be aware, even if the sling portion is very small, right now, since you're in late 50s, you may not have a lot of issues with the dry vagina or thin vagina. But later, after we reach 70s or 80 years old, our vaginal tissue getting thinning out more. When that happens, up to 1 to 3% of patients, meaning 1 to 3 out of 100 women, may have mesh exposure, meaning some part of the mesh that was placed under the urethra may be visible. Sometimes it can give some spotting, and most of the time people do not feel anything. It just found to be in the office by exam only, but that's one of the complications can happen. You need to be aware. And when you're talking about slings, there are different types of sling. Nowadays, there's a mini sling or placing in the obturator like groin area, placing behind your pubic bone. All these three are relatively effective. However, many studies shows that doing it retropubically, meaning put behind your pubic bone, is the most effective method. And if you do not want to go this extensive measure, there is something called bulking agent, which is very quick. You get it done in office. And if you don't, this one has two different types. One type is it has to be repeated every 6 to 12 months. Depends on how this material goes away, cleaned by your kidneys. Or another type, once it's placed, it lasts up to more than 7 years because this is different type of bulking agent. So for both of cases, success rate lasts up to 70 to 80%. But again, and also there's another thing that I talked about, something going through your belly and placing stitches next to your urethra. That used to be gold standard before sling procedure came out. Like during 70s up to even 80s and 90s, before this sling comes out, it was considered as gold standard. But again, if you ended up having a little C-section scar, it's more invasive because you need to stay at least overnight in a hospital, make sure your skin closes okay. And this one also, the success rate for this corporal suspension, like lifting up your urethra from above, is also good, up to 80 to 90%. And sling fascia procedure that I briefly said is basically using your own fascia layer. So people who do not want to have synthetic mesh materials, although that is gold standard, considered to be gold standard nowadays, but if you do not want anything synthetic in you, then this can be a good option. But it's also more invasive because I need to harvest your fascia from your belly or from your side leg and use that fascia lifting up your urethra. And this one also requires for you to stay one night in the hospital.
We do have a few more questions, so let's see if we can get through those.
Sure.
I've noticed that when I'm in a recliner in the evening watching TV, I'm fine. And then this person sits up and has a sudden urge to go, and sometimes it's so fast that she dribbles a little. Why isn't she aware of having to go until she sits up? She's 68, a mother of 3. One of her children was 11 pounds, God bless you. And she says, just in case having big babies had anything to do with it.
So let's go talk about a little bit about our bladder and how bladder is placed in our belly, in the pelvis. I wish I brought some pelvic models so I can show you what I'm talking, but basically can you see my hand?
Yes.
So our pelvic muscle is like this, thin, it's supporting at the bottom here, right? And we don't have any bones on the pelvic area. On top of this thin muscle, we have bladder sitting, uterus sitting, and bowel sitting. Everything is sort of supported by this thin muscle, which means above this pelvic area, we have small bowel, large bowel, all these intestines and stomach, everything is up here, right? So when you're lying down, bladder does not get a lot of pressure from your above intestine and other organs because your bladder is sitting the bottom portion of your pelvis. So when you're inclined, like sitting like this, you don't have a lot of pressure onto the bladder. But now you're trying to sit up. All these organs that were like laid back, now giving direct pressure on the bladder. So now you feel more urge because bladder starts contracting and filling outside the Valsalva force. That's the reason.
Okay, thank you.
Okay.
I'm 55, and in the last year, I've started having just a drip come out from time to time, sometimes for no reason. Why would this be?
So so urinary leakage can be multifactorial, meaning multiple things can impact. But again, I just need to emphasize each woman have different life stories. How many children they had, how big their children were at the time of they were born, and what kind of pregnancy, what kind of delivery, and how long ago her menstruation was, and how many fat cells they have, and how much estrogen hormones are around, and whether they have COPD, asthma that impact them to have a lot of coughs, or whether they have cardiac problems so that all this body makes more urinations. Everything contributes to leakage problem. So if you saying you have, that's very broad questions to figure out why you're leaking. So in a case like this, the initial thing that you can help yourself and the provider to be is writing down your bladder diary. How often you're leaking, how much you're leaking, and how many pads you go through, and how much you drink during the day, and what you're drinking. This whole thing, as well as your basic histories, will help to figure out why you're leaking small amount of urine. It could be stress, it could be urgency, it could be mixed, or if you do have prior history of brain damage or spinal cord injury, pelvic surgery, anything happened along with your nerve system, then that's something totally different from this topic. It's out of the scope of this talk. That's something called neurogenic bladder. So that has to be addressed on a separate setting. But again, urinary leakage can be caused by multiple different reasons.
Okay, thank you. Let's see if we can get through these next couple. Is there a pediatric size scope?
I am planning to get one. Pediatric size scope comes with about 10 French. Unfortunately, pediatric size scope does not have extra port. Meaning if I need to have some little biopsy or have to do bulking agent or Botox injection, there is no port to pass through. So for diagnostic purpose, pediatric scope is great because it's a little smaller, and especially postmenopause women, it's a lot easier for them to get that testing done, but it does have some limitation. However, my office is looking into the opportunity to get that available.
Okay, thank you. What pelvic floor exercises are recommended other than Kegels?
So if you know which muscles to contract, you don't need anything extra. However, all your slides, I mentioned that if you tried and we tried together, but some people, it's a little hard to squeeze the right muscle. If that's the case, there are 3 ways. One way is, the best way is you go to see pelvic floor therapist. There is a specialized therapist who knows how to teach and how to tease out the muscle of interest. So these therapists are great. If you get them work on your pelvis at least once or twice, and you can get hang of what kind of muscles you need to squeeze, then you're all set. And another type, if you cannot find, by the way, Inspira has a pelvic floor therapist. I really like her. All of the patients love her. Another option is you can get, commercialized tool, like Kegel tool or some little olive shape or little tool connected to stimulator. It's vaginally insert. So you can probably just get it from Amazon.com or something. I cannot tell you which manufacturer is best or not, but what they're doing is exactly the same thing. So basically put little vaginal insert inside the vagina, which is connected to little battery stimulator, and it kind of, when you squeeze, the machine picks up whether you're squeezing it right or not. That's similar pattern of something called biofeedback, as well as electrostimulations. Some of the pelvic floor therapists do have biofeedback as well as electrostimulation, but basic idea and basic thing is all basic, what's it called? Basic thing is all same. It's basically like helping you to recognize whether you're squeezing it right.
Right. So if your incontinence is caused by a prolapse, can you train it by extending the time between urinations?
So interestingly, if you have prolapse tend to masking your stress urinary leakage, because prolapsed vagina can kink the angle from the urethra to the bladder. So people who might have leakage from stress, coughing, jumping, laughing, sneezing, or whatever, may not leak urine because of prolapse. But people with prolapse may have something called overflow leakage or a little bit of urgency leakage. You follow me? So it's a little different mechanism. So if you're leaking from prolapse, main thing is you need to try a NIST pessary or some device, pessary or tampons, whatever, can lift up your prolapse so that you can empty your bladder completely. The reason why you're getting leakage with prolapse down vagina is mainly your bladder is not completely empty. So whatever urine left inside or completely full bladder, even if you go try, you cannot empty, then some of the urine may leak out because it has to leak out, otherwise it's going to go back to the kidney and creating more problems.
Okay, thank you. I know that Inspira and the rest of the state is opening up elective surgeries. So are all these procedures that you're doing considered elective, or will they need to be delayed? You know, the state is opening up March or May 26th. So if somebody wanted to come to you now, can they do it now?
That's a good question. Actually, any surgeries that can be scheduled in advance are classified as elective surgeries. There are 3 classifications. 1, emergent, it's life or death. Yeah, it has to be done now. Second classification is called urgent, meaning if we don't do it within 2 to 4 weeks, then it's going to be compromised this person's health. And third type is elective surgery. So basically my surgeries for all urogyn surgeries are considered elective surgeries per se. As you all know, due to the COVID-19 pandemic, elective surgery and all invasive procedures were on hold. However, we got a great news last Friday by New Jersey governor. It's now opening, it's actually allowing all these elective surgeries and invasive procedures from May 26th. So anyone who comes to my office who wants to have surgery, then after thorough evaluation, there will be no delay in terms of surgical management.
That's great.
Office procedures.
Right, right. So thank you very much, Dr. Chong, for taking the time to educate us tonight. Thank you all for attending. The presentation was very informative. And to all of our attendees, you will receive an email with a recording of this webinar. Dr. Chong is obviously available through our Inspira Medical Group practice in Vineland and Mullica Hill. And we just talked about appointments, and she's taking appointments. I'd like to thank the marketing department, Suzanne Bauer and Lauren Clinton, for all the work that they've done for helping us to prepare for this webinar. There's lots of background work that goes into this. And just as an FYI, on June 11th at 4:00 p.m., we'll host another Zoom type session on the topic of bariatrics. It's entitled Gain Your Life Back. Dr. Keith Kreitz, who is a bariatric surgeon through the Inspira Medical Group, Roseanne Ricano, who is a bariatrics clinical outcomes manager, and Brady Rojas, who is an outpatient dietitian, will be providing a panel discussion where you'll learn about bariatric surgery options, as well as the process you will receive, the process that you need to go through, and then Brady will give us some nutritional information that'll help us reach any weight loss goals that you might have for the long run. In the meantime, wear your masks, wash your hands, keep social distancing. Top of mind, stay safe, everyone. And thank you very much for joining us tonight. Thank you again, Dr. Chong.
Thank you.